I'm Jeff Elias from the University of Virginia, here to talk about neurologic disorders treated with high-intensity focused ultrasound. Recently, focused ultrasound has been approved in several countries for use in the brain to treat neurologic conditions. It received CE mark status in December 2012 for the treatment of neurological disorders like essential tremor, unilateral tremor-dominant Parkinson's disease, and neuropathic pain conditions. It also has similar status in Israel and Korea, and recently my country received FDA approval for the treatment of essential tremor. The use of ultrasound to treat brain conditions or neurologic conditions is not a new concept. Back in the 1950s, the Fry brothers, who were ultrasound scientists in Illinois, conceived of this idea of focusing ultrasound beams or acoustic energy deep inside the brain to make precise, less invasive lesions. And here you can see two large brain animal models where they were successful in achieving this. Clinicians soon recognized the potential of this technology. Russell Meyer was an early innovator in basal ganglia surgery. He performed open craniotomy procedures for the treatment of movement disorders. And he soon teamed up with the Fry brothers to send ultrasound beams deep inside the brain to the basal ganglia to treat various movement disorders or hyperkinetic conditions like tremor and choreiform movements. And here you can see their early study where they were successful in treating patients with different types of Parkinsonisms. Around the same time, a diagnostic ultrasound was born in Lund, Sweden. Ultrasound technology was previously being used and developed in shipyards and factories to test the integrity of different materials used for construction. And a cardiologist named Edler used one of these early ultrasonic reflectoscopes on the chest wall of a patient to see the wall motion of the heart valves. And this was really the earliest echocardiogram back in 1953. Another clinician in his hospital, Lars Leksell, who was really an early pioneer in stereotactic and functional neurosurgery, learned of these early procedures and adapted the ultrasound transducer for use on the neonate skull to detect a pineal shift in a child with a subdural hematoma. And he became very interested in transmitting ultrasound energy into the brain for less invasive stereotactic procedures. He even accommodated his early stereotactic frame to house an ultrasound transducer. But he became disenchanted with the need for a cranial window to send the ultrasound energy, and he eventually abandoned the use of ultrasound for lesioning and began to study the use of ionizing radiation. And here you can see the earliest gamma knife device that he developed. And so ultrasound was really abandoned in the 50s by clinicians because of the inability to transmit it through the skull. When acoustic energy or ultrasound is passed through tissue, some tissues transmit it better than others. The skull may reflect or absorb ultrasound energy. Most of it, in fact, is absorbed or reflected. But a small amount of it can be transmitted through the skull depending on the frequency of the ultrasound wave. And so there's several factors that play into how much acoustic energy is transmitted through the skull. It's not simply the thickness or the density of the skull, but it really has to do more with the composition, the ratio of cortical and cancellous bones. So we now calculate a skull density ratio, which is really the best approximation of how easily or difficult ultrasound may transmit through the skull. And one of the reasons why we're able to now use ultrasound energy to treat brain conditions is because of some of the real advances in ultrasound technology that allow us to transmit ultrasound through the skull with precision. And transducer design is very important. There are now multi-element systems where our current clinical device uses 1024 elements which can be individually controlled and phase shifted so that ultrasound beams, as they transmit through the skull, can be really deflected or refracted to a focus. And the hemispherical arrangement of the transducer also adds to the ability to converge these ultrasound beams to a single focus. We're also able to use high-resolution CT imaging to get information about the skull. The skull, it really acts like the lens of your eye and can diffract the ultrasound beams. It's very important that we bring them all into focus by converging the beams. And so the earliest transcranial closed skull high-intensity focused ultrasound procedures really performed in 2009 in Boston at Brigham and Women's Hospital, where researchers were able to focus ultrasound beams inside the brain of patients with malignant glioma tumors, and they were able to successfully heat the tumors. This early device had 512 elements and was able to successfully heat the tumors with MRI guidance or MRI monitoring using MR thermometry, but they couldn't get the energy intense enough to cause thermal ablations in the tumors. This was later achieved by scientists and researchers in Zurich, Switzerland, where the next generation of focused ultrasound devices had twice the number of elements, and they were able to achieve higher energies within the brain to create thermal ablations. And here you can see Daniel Jomonod, Ernst Martin, and their colleagues perform medial thalamotomies very precisely with MRI monitoring to treat neuropathic pain conditions. And this really paved the way for the consideration of using this technology clinically. In 2011, our institution gained access to MRI-guided focused ultrasound technology, and we were interested to use it to treat patients with essential tremor. And there are several reasons why we're interested in this. First, the target to treat tremor is relatively well understood. Ultrasound could be focused deep inside the brain to this target, and that had been successfully done in Zurich. And we really like the ability or the idea that tremor was a relatively sensitive symptom to various treatments, and we thought that we would be able to carefully monitor patients clinically during the treatment in addition to with imaging, and that we might be able to see symptom response before tissue ablation ever occurred, since this is a relatively sensitive symptom. So this is a schematic kind of illustrating the use of this closed-loop therapy to treat tremor, where we could very precisely plan the treatment stereotactically on high-resolution MRI images. We could monitor the treatment with MRI thermometry, and we could monitor the treatment clinically for patient response, and then repeat the procedure as needed. So we thought this was really an ideal clinical application for this technology. And this was the first patient that we treated. And just to walk you through the prescription of his treatment, we prescribed the first sonication was very low power of 25 watts for a duration of 20 seconds, and it did not cause any heating at the stereotactic target. And then we gradually escalated the acoustic power until we could start to see a thermal rise at the target. And you can see at sonications 8 and 9, the patient started to develop some clinical response. They developed some sensory phenomenon like paresthesia and numbness, which really tells us that we're slightly posterior from the tremor target. And we made an adjustment by just 1.5 millimeters in an anterior dimension, and then we started to see the tremor improve. And so I think this first case beautifully illustrates the potential of this technology, the precision that 1,000 beams of ultrasound could be adjusted by 1.5 millimeters for a very dramatic clinical improvement and response. So really from the first patient that we treated, we knew that this was a very incredible technology.